All right. Good afternoon, everyone. It's great to be here with you for an important panel. My name is Sharif Elnahal. I am the Undersecretary for Health at the Department of Veterans Affairs, where I have the privilege of leading the country's largest healthcare system, integrated healthcare system, for, in my view, the most deserving population in the United States, those who wore our uniform and defended our freedom. And I just cannot tell you how important this panel is for such an important conference that the President has convened. The title of our panel is Bridging the Gap Between Nutrition and Health. I'm a physician by background, and as was mentioned in the last panel in this room, you know, there are obvious deficiencies in the way that healthcare providers are trained across the country on nutrition. And the fact is, as my wife put it, who's not in healthcare, you know, you're talking about a substance or a set of substances that people put into their bodies every single day, compared to our comparatively extensive knowledge on the synthetic stuff that we put into patients' bodies to treat disease. And so that in and of itself is telling about the importance of nutrition on health, which really goes without saying. But the set of panelists we have here today will really help us understand what it takes to connect our healthcare system and caregiver system more generally, our system of care, to this important topic of nutrition. And a big take home that I think all of us will come away with is the importance of partnerships to do so. I just want to mention a few things that the VA is doing on this effort. We do comprehensive screening for social determinants of health at the point of care, and so many locations in our system are ready to include food insecurity. But also, we have a lot of initiatives to test the boundaries of what we can do to connect our veterans with food security and with transportation. $35 million of some of our expiring funds, I hope nobody from OMB is in the audience, will be going into a very innovative initiative in New England out of their Center for Innovation and Excellence. They essentially provide a rideshare program that will connect 200,000 veterans with food deliveries over the next year and 255,000 transports to vets needing mental health services. So we're really excited about that, and by the way, work that is being replicated across the country. Of course, the President and Secretary McDonough are very committed to this. I also want to give an important shout out to a set of particularly helpful members of Congress, in particular on the connection between veterans and food insecurity. Chairman Takano not only helped lead the passage of the PACT Act, which is a once-in-a-generation expansion of veterans' benefits for toxic exposures in theaters of war throughout our history, but also is very, very invested in food insecurity for veterans and is enabling us with the authority to do more and more on this. Congressman Jim McGovern is also front and center in this effort around food insecurity. We have the help of Senator Debbie Stabenow, our chairwoman of the Agriculture Committee in the Senate, who is dead focused on this and works with us all the time in terms of how this issue interfaces with veterans, and Congresswoman Jahana Hayes as well. Just a few examples of many of our congressional partners who are working hand in hand with the Biden administration on this issue. Again, I cannot wait to have the panel introduce themselves. We have Dr. Tia James, Walter Murillo, and Denise Scott. And so we'll get right to introductions in a second. But the theme, again, is bridging the gap between nutrition and health, and we're going to be dividing our session today into three parts. The first is, how do we break barriers to connecting so many patients in this country and people in this country to nutrition services as it's connected to healthcare, solutions for bridging those gaps, and then, again, the importance of partnerships in making that happen. So without further ado, I'd like our incredible panel to introduce themselves as I sit down. We'll start with Mr. Murillo.
Well, good afternoon, welcome, and thank you for inviting me for this conference. My name is Walter Murillo. I'm the CEO of Native Health. We're an urban Indian health program in Phoenix, one of 41 around the country. Our mission is to raise the standard of health amongst American Indians, Alaska Natives that live in urban areas, and part of that is addressing their direct health needs, but also the social determinants of health and we all do our best to try that. I've been with the organization for 25 years, and I am proud to be here and represent urban Indians.
Thank you so much. We'll move on to Denise Scott.
Hi, I'm really pleased to be here. This is a great opportunity for us to talk about our work. LISC is a national organization. We represent our work across about 40 of the cities around the country, including over 2,000 rural communities and native communities as well. We are deploying about $1.5 billion a year in support of social determinants of health type activity that includes everything from investments in affordable housing and healthcare centers and childcare centers, recreational programs, converting vacant lots into green spaces. So there's so much activity. I'll have an opportunity to talk about it soon, but I'm really happy to be able to sit here and be a part of this conference.
Thank you, Denise. Dr. James.
I'm Thea James. I am an emergency medicine physician by training. I'm Vice President of Mission, Associate Chief Medical Officer, and co-director of the Health Equity Accelerator at Boston Medical Center. And I don't want, if I start talking now, I'll just keep talking, so I'll just stop right there.
Well, we can't wait to get your insights, Dr. James. Really appreciate it. So I want to start, again, with this theme around breaking barriers. You know, obviously, from the point of medical training through to the tools that our clinicians have on the front line to connect patients with critical information about nutrition, but then also that critical longitudinal follow-up for patients, right? That support, that wraparound service of getting people healthy food. I want to start with you, Dr. James. Can you talk about your experiences with this, leading these initiatives at a safety net hospital in a vulnerable community? And tell us about that experience.
Sure. So our hospital is the largest safety net hospital in New England. A majority of our patients are government insured. A majority of them live at or below the federal poverty level, which means that they are challenged to, when they have diseases that are dependent upon certain types of foods, they are challenged to be able to have access to those foods. But what that results in is people coming in over and over and over again with the same problems. And that translates to higher cost. And so, you know, it's not the best way, you know, that we can address this issue. So one of the things that we've done over decades is we've recognized the gaps that our patients have. And we have done many creative things and innovative things over decades to sort of like fill those gaps. We have a rooftop farm, for example, and we have and that rooftop farm supplies our prescription or preventive food pantry, which is the first one in the hospital, that distributes about over 1 million pounds of food to families and patients a year. We also have a Grow Clinic that focuses on children who are failing to thrive. We've done many things, and a lot of these things have actually been disseminated across the country. But in the end, you know, when you really dig deeper and, you know, and actually engage with the patients, we actually recognize that the patients can't prioritize health because they're prioritizing survival. And what it's done is to make us look a little bit deeper and to begin to focus more with intentionality on upstream causes, because what we're doing repeatedly is downstream, and we'll never stop that pipeline until we go upstream. And when we talk with the patients, we also screen them for determinants of health, and what's showing up is it's basically economic challenges, you know. So a lot of what we're focusing on right now is economic security, financial stability, even wealth building. And because income is not enough, you know, you need assets in order to weather things like COVID. And so I guess we'll talk more about that, but, you know, we don't do it alone. Of course, we do it with multi-sector partners.
Terrific, and it's great to hear that all of that's happening at BMC with a community that needs it. And, you know, certainly a model for healthcare systems, including our own, to take some of those best practices. Denise, can you tell me, you know, your decades of experience with community development, the coalition you need now. Where does access to nutrition services fall under that, and to what level of importance has that meant for your work?
I think the entire community development industry today is recognizing that social determinants of health is community development. And that's a big, I think, movement forward, and it has led us to partnerships that I'll talk about perhaps from your next question. But in terms of what we're focused on now, the idea that you can look at spaces in communities, vacant lots, and make sure we can convert those lots into vibrant places, that we're connecting with farmers to bring farmers markets into community and create healthy food access. And financing community health centers. In many of our communities, there's a lack of that. Transportation is another big issue for many families. It's not just that the services may not be in the community, they may be there, but access through transportation is another barrier. We have a lot of resources today, especially because of this current administration, but local governments and community are struggling with the infrastructure to deploy. And so that's another I think, really big area. And it was said earlier in the earlier conference, the plenary this morning, that the lived experience of community is really an important component to be factored into how we design programs and how we make investments. But overarching, I would say the three things that are most important for our focus is the built infrastructure, making sure we can provide access, and building the capacity of community to do this work.
Yeah, terrific. And it speaks to all of the layers of toxic stress that vulnerable communities have, and being able to get to sources of healthy food, afford healthy food, and bring it home to their families. And your work in that is just extraordinary. I want to ask you, Mr. Murillo, from your standpoint in being part of the leadership of your nation and Native health in particular, again, where has this barrier to nutrition services existed most notably for you? And what have you learned over the years in tackling that challenge?
Sure. I think we also are a federally qualified health center as well as a UIO, but we're also a health center funded by HRSA. I think some of what we do is our dollars are already pretty thin, and what our goals when we set them from our board of directors is to assist folks in improving their health status. But of course, that means helping them find a job and helping them find housing, or even keep their housing now with the crisis that we're having with housing and evictions. But also when we think about how do we afford to pay for it when we're competing against hospital systems and doctor salaries, what are the standards that are set? We're asked how many patients we see, what are our UDS measures or HEDIS-related type measures, but we're never asked how many folks did we help find a job, or how many people did we find housing for. I think changing our priorities and changing the funding system to lead towards that would be a really great barrier. But I also think serving the urban Native population, there has to be confidence in accessing that care. Whatever services we provide to the community mean nothing if somebody is scared to walk in the door, if they don't understand that they're welcome and that they will be served. So I think part of what we're trying to do is place ourselves in an area of trust for people. And the help is there, and we'll talk about partnerships that we've managed to do to address those needs. Once they come into the center, once they let us know that they need help, we found a flourishing partnership in town for our patients.
Yeah, your point about trust, Walter, is really meaningful to me because, a lot of, especially during the pandemic, you heard this narrative around communities of color not trusting the healthcare establishment. And the way I would add a friendly addendum to that is to say it's actually our responsibility as a healthcare system to demonstrate trustworthiness and to basically earn that trust from our communities. And it sounds like you've made a lot of headway, especially with regard to this issue in your community. So let's move on to solutions. Right now, we have a good sense of you know, a lot of the barriers and the different communities that you serve. And, you know, a lot of that, of course, is affected by all sorts of socio-demographic risks that people, you know, carry. But tell me, what can we do from each of your standpoints to address that with solutions? And I'll start with you, Walter, on that.
Well, I think, as I alluded to before, and I think a focus of this group is to ask for help ourselves. We ask for help from other partners in the community to put together programs, or even to provide space for programs, from a jobs program to legal assistance. So we found partners willing to come on site and provide these services if we just give them an office. So I think part of the first step is for us to ask for help, for willing community partners, and we found that to be very, very successful. And I could go on forever, but I think some of the others is to have legitimacy with your patients, as you said, have legitimacy that we really are here to help, that there isn't going to be, and it's what's important is they understand the cost of coming in, the cost of seeing the doctor, and in fact that there's little cost at community health centers for them to access treatment. So once the fear of asking for help, of accessing help ends, it's our role, I think, to directly provide that, and community partners mean a lot.
One more follow-up question, Walter. Do you feel like the connection between the clinicians at the point of care in your health center and all of the local, state, national programs around food insecurity, do you feel like that's a connection that's effective and is assisting your clinicians in addressing this issue?
Oh, certainly, and I think that's led to some of the programs that we've had and the partnerships that we've had, finding out when we do surveys of our patients what's on top of their mind. And I think food became a big issue, and so working with some food banks, we started providing meals in our clinic. So, you know, some folks are resistant to say, you know, we're not a food bank and we're not a restaurant, but we are a healthcare provider. And so it became an easy sale for everybody to understand, yes, we're going to feed families, and yes, we're going to dedicate part of our waiting room for families to eat, and yes, we have to clean it.
Yeah. Great. Certainly do. So Denise, would love your sense of the solution set that we have with your experiences in community development in your coalition.
As Dr. James said, one of the major pillars of social determinants is the economics of the household. And toward that end, we align financial coaching and employment programs under the banner of a program we call Financial Opportunity Centers. There are hundreds of them around the country now. It's a model that we launched. And the goal there is to really help the family upskill, to get to higher employment, to really bring household financial stability to the table, which will have a benefit in terms of how it relates to the health of the household. We have forged partnerships with many health institutions across the country, and that new relationship and partnership between community development and healthcare systems and insurance companies is a big deal. And we're finding that we're both learning each other and learning how together we can influence improvement in terms of bringing down some of the barriers and improving overall the care. So it's really important, I think, for those partnerships to continue to grow.
Yes, thank you. And then Dr. James, your sense of not only the solutions happening right now at BMC, but the crucial intersection here with culturally competent care and health equity.
So, you know, it's an interesting thing. Before 2020, we were asking ourselves, what is our role, you know, as a safety net hospital? Is it charity exclusively in perpetuity, which really doesn't alter anybody's life course trajectory? That perpetual gap of need is always there. Or is it equity? We were asking ourselves this question pre-2020, and I think what happened since 2020 is, you know, there was sort of like much more visibility, or the curtain was raised or something, or opened, or whatever, the shade was raised, where we could begin to see how these things happen, begin to understand the root causes behind what we see and what we saw, and we recognize a lot of it's structural. And so, we recognize, we see ourselves as an anchor in the communities that we serve, which enables us to have a lot of impact. And we had some intentionality around how we hire, how we invest, and how we procure. Mm-hmm. And in our state, if you add or build into your facility, the state says you have to give 5% of the total construction cost to the community. Mm-hmm. And actually working with my colleague there, Dr. Megan Sandel, who's really had a great deal of interest and experience in housing, we asked the state if we could commit our small little $6.5 million by comparison others who had like $53.4 million and that type thing. If we could commit it to various different housing initiatives, and they approved it. And so one of the things that we did intentionally was to step outside the hospital in the community where our patients come from and invest in a housing development, for example, but with intentionality, because it will only approve proposals that provide access to employment, green walking space, transit, healthy, affordable food, and healthy, affordable housing. Mm-hmm. So the housing was to rent and to own, which contributed to wealth building. There was space for a grocery store, retail space on the bottom of the development. Mm-hmm. And the people in the community wanted a grocery store. So initially it was going to be identifying 2 operators, to run the store. But post-2020, we started thinking about it, and we were like, well, why should they be operators? Why can't they own the business? And why can't they own the physical space? And they hire from the community, and they focus on healthy foods. And so we invested in that and stood against, folks who thought that you couldn't do it. But we did it, just by leaning in hard and getting people to see that it doesn't have to be the way it is, that it can be much better. And so to answer your question, I think it's just about having intentionality around something very different and not giving up. That enables it to happen, because you'll get lots of reasons why it would not be possible. And over time, that changes. You create the whole ecosystem, not just in your hospital with your patients, but in the places they come from. And over time, that perpetuates itself.
Yeah, no, that's, yeah. I love the story because it's another lesson about how easy it is to forget that a solution for a vulnerable community will fall short unless the process in implementing that solution is inherently inclusive and equitable, which means hiring from the community to execute it, getting local labor involved, everything from construction to staffing it when it's up. And then the end product means more accessible, healthier food. Then you're meeting all goals with the approach, not just at the end of the implementation. Right. So really amazing. I want to get into the topic of partnerships because in such an all-encompassing issue, nobody has the ball from beginning to end on getting vulnerable communities access to nutritious food. Necessarily an effort that involves so many different stakeholders. And so I want to start with you, Denise, on this because that's inherent in the coalition work that you do. But please tell me how you found not only specific partners helpful, but the process of stakeholder engagement to get folks on board.
Right. I think the goal was really to figure out how a CDFI and community development in general could be innovative and equitable in providing the kind of access to all the kinds of services that we're financing. So we have to think out of the box. So we can finance a health sector, a health center, but at the same time, it may not be as accessible as necessary. So we started co-locating, and that required partnerships across the housing industry, across commercial activity. We have health centers that are co-located with grocery stores, with healthcare centers, and so you have to bring an array of people to the table to forge those kinds of partnerships. We've recently partnered over the last couple of years with a major ride provider to make sure that we could get families to healthcare services. It started out with get a vaccine, and now it's any health appointment that you have. And for many people, you don't need the app, you don't need the credit card, you don't need the phone. What you need is to be connected to your church, to your healthcare center, to some of the health systems health centers in your community, and we are partnering with them and paying them to make the appointments for the ride available to families. And that has been, I think, a major partnership. It is, for a lot of the work that we do is also in the recreational space in an effort to try to build healthier communities. And so we have partnerships with major sports institutions and the education system and community service institutions, building almost 500 sports fields across the country, places where started out as football and now it's sports in general, but these partnerships are providing green spaces and play spaces for kids to be active in communities that may not have vibrant parks and that sort of thing. So I think the partnerships are us all thinking outside of the box, coming out of our silos, and then figuring out how we work across our various sectors to produce that product that's really responding to what the communities need. So it's not enough for us to plan for community, but rather that we understand that these are what the needs are, and here are the various sectors that need to come together in order to realize those needs.
Yeah. Love your response, and a couple themes strike me as very relevant. The first is, it sounds like you're designing these collaborative efforts around the experience of the folks benefiting, right? And so not only is that important because you're helping folks who deserve it and they deserve a good experience, but it's also inherent in the success of what you're trying to do. Because for vulnerable communities, when you have them face to face as individuals, as families, to do as much for them as you can. So this theme about co-location, this theme about assisting in the process of getting folks to where they need to go to get these services, just front and center in what you're doing. So really, really insightful. Walter, I want to ask you about your work in particular with partners around Native Health and what you do with food banks and external organizations. How has that worked in meeting the goal here?
That's worked very well. In fact, one partnership has led to other partnerships. We partnered with Keep Phoenix Beautiful, a subsidiary of the city of Phoenix that works in blighted land to provide community gardens. And so one of the areas that we first worked on was right across the street from our central clinic. It was a historic Indian boarding school, and that had a large vacant space. And so we started gardening, and then we tied it to our meal program. And can the food we make in the garden be distributed to the folks on our meal distribution program? And we asked a local tribe if they could actually contribute to the effort, and they said, yeah, we'll do more than that. Here's the seed. We've been working on low water, high yield indigenous crops for a while as an initiative of the tribe. And they gave us tempeh beans, and then they gave us recipes. And one partnership leading to another with the food banks, and we can supplement the food that we give away from 3 food banks in the city of Phoenix, one including a faith-based food bank. I think, as I mentioned, then partners start coming to you as they hear of these innovations and things. And so we found it one partnership leading to another is a great innovative model, and you just add things as you go. And finally, I think one of the areas where getting back to the relationship of the land to the people is important in our culture. And we began working with a local senior citizen group to distribute food boxes at their homes. And during the pandemic, that was particularly important because of the isolation of the seniors, especially the Native American seniors in Phoenix. And we would, a food box delivery, to take it and put it on the porch and stand back, it takes about 20 seconds. But ours were taking an hour because they stopped to talk, the seniors would grab you, and of course, not to be disrespectful, you engage them. And I think that what we have found is that all of these partnerships lead to greater health, and you really get to see what people's motivations are, be it local government, local food banks, and especially, I want to, the USDA in believing some of the proposals that we've put forward with food banks, and they've broken their mold in some cases to fund pilot projects, and that's been interesting.
Yeah, no, it's again, just looking at themes here, the strategy of partnering and then cascading those partnerships with folks that already work well with those critical partners stands out to me there. And the fact that that leads to even more trust incrementally with the folks you're serving, because you're talking about faith-based partnerships, you're talking about people who already enter institutions of trust all the time, and then can see that this FQHC, this health clinic, is part of that network of trust. So really, really great. Dr. James, again, your experience out of BMC and beyond with partnerships to deal with this.
Yeah, so we start by asking the most important partner, which are the people. We ask the community what they need. I mean, we don't just assume what they need. We don't think we know. They know better than us. Yeah. And that's something we learned over time, and I think the most important example of that was what was during COVID, when we knew we had such low levels of acceptance of the vaccine, for example, and we reached out to faith-based members and other community members to ask us, what we should do and how we could set up additional sites in the community, what they should look like, feel like, did walkthroughs with them, our operations teams. I mean, it was really, something was spectacular, quite frankly. And that has evolved into now as having an equity partnership network, where we have different community groups that help us on different types of issues that we're working on, like equity in pregnancy and things like that, and now diabetes, those types of things. The other partnerships we've done, particularly based on things like economic development and wealth building, like Denise said, we've worked with CDFIs and even a private equity fund, but is based upon real equity for people, and other different sorts of entrepreneurs in the community that we have supported in that way. And as someone else just said, it's been a learning process for us as well, to be able to learn how to engage with people. But we sort of we follow what means the most to them, and we always want to be able to do that, because we think that way we're able to achieve at our highest level, and they are able to reap the benefits of all of that. And at some point, that sort of like becomes, you establish like a platform for others in the community to build upon that. And I would say other people we collaborate with is other healthcare systems, who have actually invested with us on certain things. And in other cases, they're actually flying off on their own now as well, doing other things. So I think collaboration is key, but in my opinion, I think it starts with true fidelity when you begin with the people, that you're trying to partner with.
Yeah, no, I love the concept of not only partnering with community-based organizations, folks that got together, built an organization in service to the community. They should be better off after a partnership with an organization with the resources that BMC has, and it sounds like you've really done that, because that in and of itself is empowering for the community. So really great themes here. I'll round out, and then I think we have a few minutes for questions. But this theme of partnerships is, I know, important to the President, the White House, the reason, frankly, that we're convening all the incredible experts in this room on the topic. And, one thing I'm really proud of is that the Department of Veterans Affairs is joining, and I see Anish Chopra back there, who really compelled all of us to do this, to partner with private healthcare systems, to partner with electronic health record companies, to standardize the way that we communicate electronically about these social determinants data on hunger and so many others. And what that will do is it will allow, from my vantage point, a veteran to make their needs known to a community provider when they need to see them, and also for us to get that feedback information into our healthcare system when we bring them back, so that if we haven't taken notice of an important social need, access to nutrition and healthy foods, food insecurity, that will just be such an enabling thing. And that's something that I think the Biden administration writ large should be very proud of, and VA is a big part of that. And I hope that our experts on the panel will consider joining too. So to round out here, I think we do have just a couple minutes for questions. Sounds good. Okay, so we have a couple actually questions online. The first I'll ask is, and feel free anyone to take it, how do we promote food sovereignty, that is individuals' own agency regarding nutrition and health?
Well, I think, and I'll start very quickly, I think that starts, as you asked, how do our providers get involved? I think that's how they get involved. But having a sort of integrated system that we have, how do you convince one to become healthy through diet? Well, you have a nutritionist on your care team. So I think even within an integrated health system, having those things readily available to a patient, when they're diagnosed as diabetic, they have to change their physical activities and they have to change their diet, but you also have to address, their mental health issues. So an integrative care team that has been a great solution for us.
Great. Thank you, Walter. We'll go to the next one. How do we make healthy eating easier? Bigger picture question.
Well, one of the things I'll say is that when we first started funding food pantries, we realized that it really wasn't enough to just bring fresh food to the community, but we started developing cooking classes. We started this conversation with community, what do you like to eat? And then how do we kind of shape the pantry, not into the food that maybe people like that they maybe shouldn't, but something that will be as satisfying as, but you have to understand where people are. And so once we started adding that sense of what community wanted along with the healthy food, and then giving people choices within that and teaching folks how to prepare food that maybe they weren't accustomed to preparing, was the only reason why they wouldn't eat it, is because they just didn't know how to, made a major, major difference in the volume of activity within the food pantry. Suddenly it was hip to shop at the food pantry.
Sorry.
Well, I love ending on that note, and I have to end on that note because I'm being waved off. But I could speak to this group for hours. Thank you so much to our panelists. And again, thanks so much to the conference organizers who enabled this discussion. Really appreciate it.